Good morning, everybody. We'll start the acute coronary syndrome session. I'll just call my dear panelists, Dr. Ahmed from Kuwait, Dr. Hani Atebe, Dr. Ibrahim Al-Rajdan, and Dr. Abdul Majid Al-Zubaydi, and Dr. Naif Al-Asiri from Saudi Arabia. Also, Dr. Ahmed Magdy. So we'll start with the first presentation. I will invite Dr. Ahmed Magdy, is a consultant cardiologist from National Heart Institute in Baba in Cairo. He's also chairman of the Egyptian Board of Interventional Cardiology in Egypt. And his talk will be unusual acute coronary cases and interventional cases.
Good morning, everybody. Thank you for the invitation, Professor Musa, Professor Abdullah, Professor Fawaz, and Professor Khaled. And congratulations for the successful event like every year. So this is our Egyptian Board of Intervention Cardiology. We are now graduating almost 30 fellows every year. Who is unusual or high-risk PCI, atypical presentation scenarios, atypical ECG, diagnostic data, elderly, renal, young and very young, difficult to identify the culprits, high-risk anatomy, previous CABG or MI. So you can see that it's almost 30% of our acute cases are unusual. This is a case that came last year during the era of the COVID, came the Heart Institute after 4 hours of acute chest pain, enzymes and CAT diagnosis, left main thrombus, but you cannot identify the lesions, almost thrombus, and you can also see that it's also in the CX in the other vessels. So the wise decision was to keep the patient on antiplatelets, and of course they gave him lytic therapy, and they kept him in the hospital. And then they photographed the arteries again after 2 days, and it was more clear. The thrombus is still there, but it's much less. And then we just did provision stenting for the left main LAD. So this is one of the hundreds of cases during the COVID that you have to consider the situation and the acute inflammatory process in the coronaries. After that, they just did the provision stenting for the LAD with wiring the CX and the LAD, and the lesion had appeared. This is another patient last week. This patient came for elective angio. He had restenosis of the LAD. Many times when the cannulation of the right is difficult and then the catheter goes into the LV and you take it out and automatically it enters the right coronary. But be careful when the right coronary is diseased. There is apparent lesions here. You can see that the catheter just jumped in the right coronary, created this dissection. And then you can identify that this dissection is already in a diseased segment. And of course, he had distally bifurcation lesion of the right coronary PDA and postulateral branch. So the first thing to do is to be careful with the cannulation of the right coronary, and then to stent these segments, and then work on the rest of the right coronary, the PDA. We just did also provision stenting. We stented the PDA, we ballooned the postulateral branch, and it ended up by a big PDA and big postulateral branch. And don't ever think that this small branch, the PDA, the postulateral branch, it's small. It may be giving supply to the AV node, and so you should always wire it, should not ignore. We had some patients that passed into AV block when you just send the main PDA. there had been a binge or it's already a disease from the beginning, so we did kissing balloon for that. The rest of the procedure is as easy as you do every day. We just stented the PDA and the kissing balloon, and then we went to the mid segment of the RCA and also stented. This is another patient example of the patients who present with heart failure, no chest pain, diabetic, and then you discover that there is critical lesions in LAD that is causing what we used to know as hibernating myocardium. There was viability of the LAD, and if you improve the coronary circulation in the LAD and probably also the diagonal, then the heart failure, whatever you give interest to or any anti-failure treatment, it will not improve. The heart needs blood. This is another extreme case of ischemic cardiomyopathy, ejection fraction 20%, and no chest pain, and obviously, because there is no coronaries, almost they are thread-like. In this case, you have to have a heart team, and you have to improve the coronaries as much as you can. This is another example of patient we saw a few months ago, coming from other countries. He had MI a few months earlier, and as you see this unusual pattern of the LAD, that we defined as it's woven coronary arteries. Different theories, whether this is acute infarction and then recanalized with collaterals and giving this pattern, or he might have this pathology since long time. It is not very dangerous to go through these collaterals or these woven segments to improve the coronaries, but it's not a common thing. This is an example of a patient who came to the cath lab, and he has double bifurcation. He has a bifurcation of the LAD diag, and there is a nasty lesion there that we treated with Dickey crush. And then he had also a tight lesion in the left main LAD that we just did for that provision stenting. So if you spend a lot of time in the LAD diagonal, and then simply you can treat the left main. So those are the cases of double bifurcation. Be careful of the contrast you are using, the procedure you are familiar with, in order to have good result at the end. Again, the rest of the procedure is like all my colleagues have shown in the previous days, but we started with LAD and diag and ended up with the left main. So this is a 69 years old, acute coronary syndrome in July 2020, LAD totally occluded. For some reason, they failed to open the LAD. Then she traveled to the States in January. PCI for the LAD, the total lesion, it also failed. I don't know why, but they stented the LAD and the distal left main, ostial LAD and distal left main. And then she traveled back to Egypt. She was followed up in Upper Egypt with some of the colleagues. Repeated angio, repeated echo was showing at some point deterioration of ejection fraction. So they did angio for her, and this was the result. This is the right coronary, this is small right coronary, and you can find out that the LAD that they stented, now she had severe stenosis of the ostial LAD, right restenosis. At the same time, the manipulation of the LAD and left main created another very tight lesion in the CX, in the ostium of the CX. And remember that still she had also a total LAD occlusion. So first thing, we work on this to disengage this anatomy. So first we balloon the CX, and then we kissing balloon for the LAD and CX ostium, because she's now living only on the right, that is not dominant. And then stenting the CX as a main artery, main vessel, having in mind that the LAD is totally occluded. So we stented the CX, and then we tried to improve the LAD ostium, but when we passed the wire, we found that it's not very difficult to pass distally to the LAD, recanalize, reconstruct, improve, and the stent. And so don't take all the messages that coming to you that this is a failure case or this is impossible to do. We did not spend too much effort to open the LED. That there's 2 trials, one in Egypt and one in the US. We opened that and we stented the whole LED. But first start to solve the problem, which was the CX and LED, mainly the CX, that was critically diseased. Now you can see LED. Simply we stented that. And then when we reached the left main part of the LED with the CX, this is another complex that you have to take the decision for. And the main vessel for us, if you remember, it was the CX. And so we did like a reverse tap for this LED CX. And the issue that the left main was very short, but we were able to do that. So remember, she had only the right that functioning, restenosis LED ostium, and the critical lesion new in the CX. And this was the final picture. And the patient was well during the last year. This is another challenging case. This is a 70 years old coming from Sudan, acute infarction. They did primary PCI for her. And during the angio, for some reason, the wire passed into a false lumen. This is a simple case, but it happens in some situations, but never to inflate if you are not sure where you are. And so they passed the wire in false track and they inflated twice. And so they created a dissection hematoma in the LED. She came to us after 25 days in severe unstable angina. The ejection fraction is not too much impaired, still viable. And now she had a big dissection, and the options that this dissection extends down to the lower part of the LED. And can you pass antegrade, but there is a big hematoma, you cannot see the true lumen. So prepare the IVUS, but how to go antegrade without increasing this hematoma? I had with me some of the colleagues, and so we thought of something unusual in these cases, but it's usually other things. This is a hematoma, still so big. We had the hope that hematoma had healed, but this is not, it's even increasing. So we thought of having this only little part of the LED functioning, so to consider it like a CTO. And so we tried to pass the wire through the septals before this very long hematoma, and then reaching distally, the most distal part of the LED. This is the only way that you can know where is the true lumen. It's only a small segment. So we did that. So we use the CTO techniques for a non-CTO. Can you give me? Sure. Yes, please.
2 minutes, please.
Okay, thank you very much. So we passed the wire. We tried to find which septal, they are not very good also, but one of them was reaching the most distal part of the LED. And we reached this distal part, and we put the wire anti-retrogradely and then going up. And we kept it, and we used another wire just to parallel to it. But while doing that, accidentally, the second wire passed in the true lumen. And then we found that we are already in the true lumen. We used the IVUS to make sure that we will not do the same mistake. Then the rest of the story was easy for us. We just we just inflated, squeezed the hematoma, improved the artery, and then reconstruction. And we created, alhamdulillah, we reached the true lumen. We were sure we are inside, and we were successfully able to reconstruct the artery. So sometimes you have to go out of the box to solve unusual situations. Thank you very much.
Thank you very much, Professor Ahmed Magdy, for the nice cases. Any comments from our dear panelists? Dr. Hani Atebe, do you have any comments? Tafadhal.
Thanks very much, Magdy. I think you highlighted some unusual pathology in some of the cases, and some of it is perhaps a bit more routine in practice. My question to you is the impact of COVID, which is we're coming out of it, recovering at present. How was that changed or impacted on your practice during the COVID pandemic? Type of cases, service redesign, all of these issues. Thank you.
Yeah, of course, there are people who are more experts than me in treating the COVID, but speaking of the cardiac cath department in the Heart Institute during the COVID, at least 15% of the cases, they were COVID positive. And then according to the guidelines set by the EABCI and by the SCI, whether they are high risk, then you have to go through and take all the precautions and deal with that, or you can just give lytic therapy. The lytic therapy was given more during this era. Then you have to be wise, because if you just inflate anything, you may create more problems. And so we were selective in our patients. We did not do primary PCI for all the patients. We only did it for the high-risk patients. And like this patient, we had so many patients with normal coronaries or mild lesions with thrombi. I think you have the same.
So I'm going to just share, if I may, Chairman, our experience. We did totally the opposite. We redesigned the service that all patients will come for primary PCI, provided that they can reach the hospital within the target time. We created a space in other hospitals for COVID patients to be admitted to high dependency areas and ITU, and we became a green zone, i.e. we don't take the hot cases of COVID, but we did primary PCI, and therefore our numbers are actually totally the opposite to what happened in the world, has increased by 10% because we expanded our area. We did not use the thrombolysis except for a very small handful of patients who lived in remote and rural, and that's was our service design. Thank you.
Any more comments, anything from my team?
Just
Please.
a lot of the cases you showed, great cases, but many of them would probably be surgical. So I was just interested to know what kind of discussion goes on with the team, with the surgeons. Do you even take their opinion, or how does it work?
Yeah.
Because some of them, you know, looking at the literature, low EF, viable, 3-vessel disease, very complex, instant restenosis already. The patient has demonstrated ISR, and you want to get into this ISR again. So I was just wondering.
Yeah, of course, I'm biased for intervention. I cannot deny that.
Sure.
But all these cases were acute, except that patient with the double bifurcation, LED diag and left main. And for that, there was a heart team. And then we decided to do. He was elective case, and he was refused by surgery. Probably he was overweight. They are selective in their also criteria. But most of the patients were acute. And we cannot deny that, yes, we also, all the acute cases, STEMI or non-STEMI, we try to solve it because the patient is already in ongoing scheme.
Thank you very much, Dr. Ahmed, for your nice presentation.